Whitsitt has evolved over the years into dual diagnosis and chemical dependence treatment center, so residential rehab. It's one of the last 2 state-funded residential facilities in Maryland. I think there were 7 at one point. And our primary catchment area is the Eastern Shore, so from Cecil County on down to Somerset County. The bulk of our patients our referrals come from Cecil County. That's 50% of our admissions. Kent County is at 20% or so, and Queen Anne's County is second. You know, the more populous the counties, the more referrals we're likely to get. We have a detox program. We have 8 beds for detox. We have 26 beds total, and if we don't have 8 detox, we fill that with someone who is not in need of detox. Our average length of stay is 21 days. We also have 4 beds in the crisis bed unit. More on that later. The detox protocol is for alcohol and benzodiazepines, Librium, Valium, Xanax. Detox from those chemicals can kill you, alcohol in particular. And we also detox for opiates. We've had a huge influx of heroin addicts because heroin has flooded not just the Eastern Shore, but the country. On the Eastern Shore area, when state and federal regulations tightened up regarding opiate-based prescription medication, Oxycontin, oxycodone, Vicodin, etc., people shifted from prescription pills that were opiate-based to heroin. And we've seen a big increase in that. The heroin that's on the street now has a high purity level, so you can get very high with nasal inhalation. So that needle stigma which deterred many people over the years, is gone. And once you start using heroin for a while, you get into the mindset about using heroin, and your attitude about it changes, and it makes it easier to make that small step from nasal inhalation of a lot of heroin to injecting a smaller amount. It's cost-effective initially, but the addictive properties of heroin have people using more and more. Where you buy $50 worth of heroin, it's better than buying $150 worth of Percocet or Oxycontin after a time. And as your tolerance develops, that $50 worth of heroin doesn't do the job that it used to do. So you have to buy more. And then a lot of times people have some sort of intervention, and they get into treatment before they make the change to injecting drugs, but usually we don't get them until after they've made the conversion, and things are really getting bad. Our referral sources are the county health departments in each of the counties on the Eastern Shore. We try to make it as easy as possible to get into treatment. When someone signs up for treatment up front at the Kent County Behavioral Health, if we have a waiting list, which is usually the case, we try to keep them in treatment in the outpatient setting to do some damage control until we can get a bed for them. The bulk of the people that are on the waiting list are in need of detox. Since we only have 8 detox beds, that creates a logjam. And we're restricted by budget. The Affordable Health Care Act is a boon for outpatient treatment. It makes treatment accessible and affordable. But residential treatment is such an anomaly that they didn't figure us into the legislation. So we can bill for detox, which is at the last minute they put that in as a necessary medical procedure, but after detox they won't pay for residential treatment. We're still grant driven. That'll happen at least for another year. We're not sure what's going to happen after that. When I first got in the treatment business in the 90s, at outpatient services, there was alcohol services, drug abuse services, and mental health services. And none of them overlapped. If you were a 55-year-old man that got a DWI and had to go to treatment, but you smoked a joint in high school, you were in the drug abuse section. And there was no mixing, which didn't make any sense, but at the time alcohol was king. And as time goes on and more drugs are readily available, it's hard to find a pure alcoholic anymore. So in the mid-90s, the drug abuse services and alcohol services merged, which made sense. But still there was a separate entity that dealt with mental health. And I remember the current thought process about mental health and addiction was that there were two things. One, that the percentage of people in the addicted population that had a mental health problem was the same as the percentage of people with a mental health problem that were not addicted. And research has proved that to be completely wrong. And the other was that you couldn't make an accurate mental health diagnosis until the person had all the drugs and alcohol out of their system. And in most cases, that's okay. But someone with clinical depression that comes into treatment and you tell them you're not going to get any antidepressants because we want to get a true picture, and two, we're going to take away your number one way of dealing with depression, alcohol. It's amazing more people didn't do something drastic, but it caused a lot of trouble with and a lot of relapse from people that would get clean and sober and they go, if this is recovery, you can have it. My anxiety's off the charts, I haven't slept in weeks, I'm depressed. So the next step in this evolutionary process was having mental health services and addiction services merge. And we're in the process of doing that now. And we have more cross-training for dual diagnosis. We had a training last week where a good portion of the people were mental health people who were learning about chemical dependence, and the rest of the people were chemical dependence people who were learning about mental health problems. And that makes sense. So we're able to recognize that you can be an alcoholic, you can be a heroin addict, you can also have anxiety. The lifestyle produces a lot of post-traumatic stress disorder and is anxiety driven. And people with depression start to medicate. The last round of statistics say that 80 to 90% of the people with addiction problems also have symptoms of a dual diagnosis. And that makes sense if you look at it from the perspective that a mental health diagnosis is ever changing. Someone who was ADHD off the charts at age 13 might not need medication at all by the time they're 18 because their brain has changed, they've matured, they've grown out of it. They've also made behavioral changes to compensate for the attention deficit hyperactivity routine. And it's the same with people who have bipolar disorder or depression. Under stress, those symptoms are exacerbated, they're worse. But as time goes on, if you get into recovery and you start feeling good about yourself, then the stress levels go down, you're better able to recognize the onset of a depressive episode and address it sooner. So that, one of the reasons we talk a lot about 12-step recovery, and one of the reasons that we advocate for people to stay in treatment as long as possible, is because they can make behavioral changes that will help increase their quality of life. When they finish detox, they go into counseling, residential counseling. A bunch of different names for it, but that's the easiest one to remember. And they get individual counseling, they have group counseling. We talk about developing sober social support, people who are doing the same thing you are and want to move forward with their lives. We talk about coping skills and stress management that don't include stopping in a bar for a couple hours. And we encourage people to find a higher power, church or the AA or NA group as a whole, doing together what they couldn't do by themselves. So we try to get the ball rolling so that when they leave here, when someone completes a 21-day stay at Whitsitt, they are completely detoxed and they have a foundation in how to move on with their life. And we want them to continue a therapeutic contact, an outpatient. Every patient who leaves here after completing has an appointment or at least contact information with the next stage of their recovery process, which is sometimes it's a halfway house. We also want people to move further into recovery so they can go from the intense treatment of detox to a little less intense residential treatment, to a lot less intense outpatient treatment, to self-treatment, which is going to 12-step recovery, AA, NA, Christians in Recovery. There are a lot of options out there now. And we also have opened the Recovery in Motion Center, which is a alcohol and drug-free resource for people in early recovery, people who are in recovery. Most of the people who come have recently completed treatment or are still participating in outpatient treatment, and they need some questions answered. We afford a wealth of opportunities for people to fill out their resume, do a job search. We have computers. We have family meetings and gender-specific meetings. We have care coordinators, which is part of the idea of recovery-oriented system of care, which is a state program that includes having someone, a care coordinator, for example, will meet someone in the Whitsitt Center and say, well, what can we do to help when you get out of here?